I think Debashish, there is no introduction for this audience. You see, Debashish is a diabetologist of a very international repute, and he is also a great organizer. I'm also very privileged to know him. He is, I would say, you call addicted. I would say addicted to prevention of diabetes through education, because his dream is to popularize diabetes education. Which is not only an essential, the most essential component for diabetes care. So, without wasting time, may I request Devashish to make his presentation.
I think I'm on mute, right? So, thank you, sir, for giving me this opportunity to speak in such an august forum. I would like to start by saying that this is a very important day for all of us in the world. Today is what we have been, Professor Azad Khan and the entire team of BADAS, and we here in Bengal to start with, and the entire country. We believe that there should be one day dedicated for the cause of serving to diabetes. I mean, we know diabetes for 5,000 years. We know that the numbers are just keep on increasing. We have done so much of research, so much of translation, I mean, really translational, transformational research. But really, when you look at the numbers, it looks so wary that the numbers say one dies in 6 seconds, 7 seconds, 8 seconds, and we don't go beyond that. So I think this is the time that we need to understand that we should wake up and do something of a different kind. And perhaps this is the time to act now. So I will rush through these slides that I have. And this is me and my baby angel from the organization, who is an educator. So we say we have a theme. We have a theme for last 4 years that we have been observing our international conference. The theme is Diabetes Educator, a time to pair up with. So initially, the first year was dedicated to the patient. Second year to people like her, called Sneha. Third year was for people like us, Seva Brata. And this year, all three will combine. You'll see tomorrow when it is all going on air from Calcutta. So my topic is a very sensational topic. And I think we all need to pay very good heed to this, that the health equity cannot be concerned, only with health seen in isolation. Rather, it must come to grips with the larger issues of fairness and justice in the social arrangements of it, including economic allocations, paying appropriate attention to the role of health in human life and freedom. This is, of course, that very famous quote by Miroski: "In education has an enduring and consistent and a growing effect on health." This is from India, that the entire population, we have almost around 76% more, 77% of the people who are not within control. And the next slide is, this is the health expenditure of my poor country. We are even in the BRICS category of countries. Look at the expenditure. India has $75 expenditure, and this is the distribution of the direct costs in diabetes care. Hospitalization, monitoring, doctor's visit, the drugs, and the other kind of tests, etc. involved. So we are overburdened. And this is an underfinanced healthcare system, both in India and Bangladesh. I think we are even low. And it is 1 to 1.5% of the total GDP that we spend out for only health, and that too even less in terms of diabetes. The hospitalization numbers are increasing. This is all the data showing that whether it's urban or rural, the divide is closing, and significantly higher prevalence of catastrophic expenditure is happening in the poorest quintile, and that is very important. At the poorest quintile, they are getting poorer. The median private sector, the out-of-pocket hospitalization is now 4 times more. And I belong to one of the private sector's hospitals called Apollo. And, the difference between what I do in the morning and in the evening where it's day, where it's my organization, Diabetes Awareness in You, it's for the common man. There's a stark difference. The medicines, cost heavily. and there is significant inequity in the utilization of public health facilities. Obviously, who else but Jocelyn said that the diabetic who knows the most lives the longest. And the art of medicine is therefore intricately tied to the art of communication. And we know that this is the data. This is a very awful data. I mean, not an awesome, it's an awful data. It's a ghastly data, sharing the fact that, see, India and Bangladesh put together, this is from BMJ Open by Irving. This says that average time spent to a patient by a doctor in India is around 2 minutes. And in Bangladesh, it is even less than that, less than 1 minute. So how do you expect people to give that time to the cause of service to the patients? Now, this is a kind of a survey which was done where Jaya Tripathi said that the average doctor in the hospital, very extensive study done, said that we see 200 patients a given day. How can we devote more than 2 to 3 minutes? And this is the ratio. One government doctor is there for 10,189 people. And one nurse is for 483 patients. An abysmal number in terms of really people doing something for health. Mind you, in India, 65% of the health expenditure is out of pocket. And that is actually pushing India to poverty just because of the health reason every year. 57 million people are kind of below the poverty line. This is, I'll talk about this wonderful model education program. And this is from the 10 Latin American countries published by Gagliardino. Way back, I think it was almost 10 years back or 20 years back, I believe. So this was about, see, look at this is minus 6 months before they intervened. And this is 1 month after intervention. This is 4 months after intervention. This is 8 months and 12 months. See the numbers. Look at, fasting blood sugar was 10.6. At the end of 12 months, it was 8.7. A1C was 9 to start, and it became 7.8. This is all about education, mind you. This was just from the people who got the education, and this is the turnover. The control was people who didn't get the education, continuing the same medications. It held good for blood pressure, cholesterol, triglyceride, everywhere. And this is the best part. Look at the annual changes in drug intake. People who started on drugs obviously started doing better. And then with the education and lifestyle, they reduced the number of drugs. In fact, a lot of them came out of the drugs. So the total was 62% decrease in all the drugs combined, whether it's anti-diabetic, anti-hypertensive, or anti-lipidemic. So this program gave us the idea that educational approach promotes healthy lifestyle habits and empowers patients. It has to be designed on each patient's need individually, that patient-centric approach, 20 years back, mind you. In Zuchi's paper, in ADA-ESD guideline, very categorically said about that, but this was given to us in understanding 20 years back. And we would like to prioritize the other factors for the patient, his feelings, his expectations, and follow exactly the changes that is happening in the lifestyle after the intervention is done. Mind you, moreover, the education of type 2 diabetes should be constant because there is a tendency for knowledge to decline over time. And consequently, the long-term maintenance of the beneficial effect of intervention has to be upheld. Now, this is from the Asian population study, a study done with low literacy color booklet, motivational video, restricted diet, and the plate diet mechanism. The chat, the UChat, this WeChat is a kind of a WhatsApp group with a lot of lectures given into it, and the targeted treatment, group medical visits, improvement of the uptake and adherence to medications, and lifestyle interventions. And they also had finally the self-management educational interventions very clearly monitored and guided. This was the logistics that you had lifestyle was given to you. Whether you were achieving targets, yes or no. If you had achieved the target, then you'll be followed up 3 months later. If you have not, then you'll be monitored. The team will communicate and adjust your treatment plan and monitored monthly. What they came out, again, an astounding data. Look, minus 0.87 was reduction of A1C. Look at these values. The cholesterol coming by 22 milligram per deciliter, 11 for LDL. Systolic blood pressure coming down by 13, diastolic by 3, BMI by almost 1. So this is completely on the systematic health education model. These numbers came down. And why? How it came? It was not face-to-face. It was basically on the health education materials, the booklets, pamphlets, video. Audio is also very important in disseminating. We have FM radios and other channels. You can play them wherever you're moving, in the car, at home. So you have the urgency that these mechanisms have to be involved, because we have a dearth of diabetes educators. And these are the data, from US DPP and the Finnish DPS efficacy data, that when you intervene very strongly with a high frequency on a weight loss program with this PIPE element, PIPE means penetration, implementation, participation, and effectiveness. The metrics showed how beautifully they corrected all the defects. This was done again almost 10 years back. This was done 10 years back. The reported was 5 years back by Aziz. Many available prevention programs were taken into this study. They observed for 15 years. And from this perspective, they understood that whatever is happening, if you actually target the population on a very large base, only this can be very effective and this can be sustainable. Otherwise, just a small pocket program pilot study does not really mean much. We know about this. Now I'll come to very hands-on kind of things, that insulinization. I'm extremely fond of insulin and insulinization. So this is how the status of glycemic control fails. Whether it's from the resource system, whether it's from the healthcare provider factor, whether it's a patient factor, whether it's a treatment-related factor. Finally, the patient doesn't really attain much of a benefit. I mean, we see patients being on insulin. That said, I'm taking insulin, fine. But what is your A1C? It is 12. I've been taking insulin for the last 6 months.
You want right answers also?
So, why? Now the question is, you have to ask that person why. Yes, that's a question. You have to focus on areas, what are his problems, whether it's diet, exercise, whether it's other medications. What hurdles are you facing? What hurdles is he facing for insulin, whether it's pain, whether it's a negative belief, whether somebody from the next household neighborhood has come and said, no, you'll die with insulin. My father died the day he took the first dose of insulin. Do you have family, friends, employer, they help you? There are a lot of questions that you need to probe: depression, stress, whether you're doing really self-monitoring blood glucose, where you see the blood glucose levels and interpret them and then act on that. What are the hurdles you face as a HCP, or what are perhaps my language is not very communicable, perhaps I'm not putting in that time. So where are things going wrong? So I will come to this slide where I'll say, look at these 4 parameters: lifestyle changes, in adhering to medical recommendations. These are the categories. Difficulty integrating diabetes medical recommendations to work-life schedule. And I have, these are absolutely real-life data. One says that I eat, whatever I eat, and my medications, they're not consistent. I often forget. I wake up at 8:30 for my breakfast. 8:30 is my breakfast time. But often, because my son going to school, my husband leaving late, I cannot have my breakfast before 10. So there's a lag, from the last dinner dose, and maybe she has hypo, maybe she has issues. This is a Brahmin, Bengali widow. She says, I'm fond of mishti. Mishti is sweet cakes. Sugar and rice are my staple. So how can I come out of it? Because, as a widow, these are kind of traditional cultural norms that she has to abide by. This is a young boy who hates, having this oats every morning. So switch to cornflakes and muesli. His sugar's gone haywire. This is an elderly man who had a stroke, so he can't really put in his exercise. So this is lifestyle. The next is a psychosocial issue that, somebody says that maybe I'm, getting old and, the days are passing. So, he is worried. There's somebody who says, I might, I purposely miss my insulin because I'm tired. This man says, well, I go to the gym, I do my exercise, but I don't see anything happening. My weight is not coming down. So I think nothing will happen to my sugar. So, these are the things that we look at, and we have to address these problems. Similarly, this is diabetes-related, treatment-related factors like people having hypo, sad memory of that. Then this is blood sugar goes also high. So she eats more, she's become more fat. This is whenever I eat at 8, because the doctor has said, have an early dinner, I invariably feel hungry, and by 11 o'clock I start gorging again. So I have more food even at night. My sugar's gone from 9.2 to 10.1 with insulin, so I'm not doing it the right way. And finally, the lack of knowledge and the self-efficacy in diabetes care. That my needles are finished, I don't have salary, my COVID-19 days, nobody's paying me, and I cannot check 4 times a day with my basal bolus. This is where I don't know why my doctor wants to lower my sugar, but I think I do not know what the target is. He said, your sugar has to go down. Now, what have I to do with that? He just, whenever I go visit his clinic, he rebukes and reprimands. I don't feel like going back to his clinic. And there are a lot of doctors, in fact, who feel very, apprehensive about doing this insulin titration well. Perhaps there are a lot of doctors who are not confident, not very trained. I mean, forgive me for saying this, but we need insulinization, intense insulinization program in this world. So my final issue is you have to have ideal diabetic care. And for that, it has to be affordable, reasonable quality, reasonable cost. And we need to have continuing diabetes education. And mind you, I will just run through these slides saying that this is what we need to understand, that every patient should understand that there's a system in which he or she prevails. There's an internal structure, stakeholder input, quality assurance. Someone has to find whether we're doing the right thing. He or she is doing the right thing. There has to be a curriculum. There has to be individualized curriculum. There has to be ongoing support from all the stakeholders, the pharma houses, the government. The participant has to understand the progress and see the quality of improvement. These are the scores that we need to do. These are the scales that we need to understand that in India or in India and Bangladesh, our kind of South Asian setup, it's a bare bone setup, one doctor, a lot of patients. So, and there's less of time. So whether you can really think about a precision diabetes care, I mean, is it at all possible? We know about this, group study in Scandinavia, in Lund University, where they have categorized that these are the, disease spectrum of diabetes population that you think of. And on the basis of that, they can actually design the preventive measures. Similarly, Mohan et al. Published August 22nd. It's a kind of an Indian cluster where it is almost akin to the Scandinavian cluster, but with some of difference. So if we know that, how can we actually hit these people the right way? How can we give them the right approach with precision medicine? Perhaps you and I, as doctors in the community, we are unable to do this. And time and again, we have shown this. We have to know about all this as well. We must understand that whether it's a woman, whether it's age, we have a lot of issues that work as deterrent for us. So we need to understand that whether it's a female patient also, we have to categorize our thought process into education. And whether it's a low-income country, the Diabetes Management and Resource Limited, look at all the tablets, the medicines, OHs. It is not available. The insulins, they're not available. The syringes, pens, they're not available. So what are you looking at? What are you waiting for? If you have to galvanize your country, I mean, like Azad Sir has done for Bangladesh, the entire team, like Barbados, Bangladesh, they have free insulin as resource poor countries, not as developed nations. We yet have not achieved that. We are trying from our policy advocacy groups. But what we understand now is that we need to do this kind of a democratization of technology and access to information. And with one single button press, we need to achieve that DSME and the diabetes management should happen. Internet in India by 2020 or Bangladesh by 2020. A lot of things are going to happen. A lot of time for consultation and education. And mind you, this is something that, me and she's Kiran here, will join in right now. This we talk about the physiological needs, the Maslow's needs of hierarchy. And this we apply when we do it in our grassroots practice. So over to Kiran. She is the person who actually takes the entire, now the responsibility of carrying the organization and my work, making it much easier than me. Thank you.
So, good evening, everyone. Good afternoon, good morning, on whichever part of the world you are. A big namaste all the way from India. My name is Kiran. I'm a diabetes educator from Diabetes Awareness and You. And in continuation to the topic of today of health education, where we are mostly talking about people with diabetes and how we have to overcome them, giving you an educator's view. I'd like to start with a quote which is very famous from Benjamin Franklin, which said, "Tell me and I forget, teach me and I remember, involve me and I learn." On that note, giving you a thought to ponder upon, we are talking about a lot of barriers that come for diabetes education. I think the crux of the matter, and most importantly, where it all starts with, is the patient-provider ratio format. So are we really doing it in the right way? A single patient meeting a single doctor in association with him in a chamber, are we really doing it right? Don't we need another approach to this? Here am I today to tell you more about how we can improve a lot of things around a person with diabetes just by the way we meet them and treat them. Bringing to you this concept of shared medical appointments. It all starts with arranging the medical appointment in such a way that not only the doctor but the entire educator team gets involved in meeting the patient in the few hours that the patient spends in the clinic. This mainly revolves around self empowerment with education, and naturally it pertains to a patient centered approach than against a disease centered approach, which is what we currently follow. This all in all has made a very drastic shift from where we have moved from general knowledge around diabetes to actual clinical outcomes that are facilitating a lot of behavioral changes in people who are suffering from diabetes. In addition, all the information that we distribute to the patients is becoming patient centered, which is really helping the patient to adapt to that behavior change, which is in turn empowering the patient and enhancing the quality of life of all our patients who are dealing with this disorder, which, mind you, we cannot pertain to an antibiotic dose of 5 days. It goes on to a 24/7 activity into 365 days, which lasts their entire lifetime. So the highlight here that I would like to make is it is all about self-empowerment. If we are talking about the barriers to education, we are in turn talking about the self-empowerment barrier, which is coming from the patient and educator relationship. We can fulfill this. There are a lot of advantages of this shared appointment. Looking from the patient's perspective, it provides a peer support group to the patient. It also motivates the patient and educates the patient not only in a single language that is provided by the provider, but his peer group, their understanding, their discussions, their feelings towards the disease are also expressed if the patient is met in a group. In addition, a lot of myths are busted, which are in the minds of the patient. Sometimes they feel shy. Sometimes those kind of questions don't occur in their mind, but they are coming across it. So they know they can come across a lot of answers if it's a group discussion, which they never thought they would ask. They can use this as an opportunity to learn from the others, and from their lived experiences, they can enhance their own life. This support which comes from their peer group, they probably have the same concerns which they are facing, and maybe they have battled it in a much better way than the others, which can now be learnt from this patient who is struggling. This is a fantastic point which is there. The time that is spent between the patient and the provider can be cumulative, and that 90 to 120 minutes which you would distribute between 20 patients can now be given to a single patient in a group. A good 2 hours, you can counsel them, you can touch upon the different management techniques that the patient can adopt. A lot of storytelling, a lot of inspiring stories, a lot of discussions can take place, and this also enhances the communication between the provider team and as well as the patient group. They feel less isolated, so they don't feel alone in this battle. I also have experience with a lot of type 1s. When we bring them together, they want to play together, they want to inject the insulin together. Insulin suddenly becomes like this fancy thing that all of them are doing together. They all want to give their bolus shots together before they eat their meals. So it's a very good environment, as again sitting alone at home and just feeling that I have to bolus myself some 3 times along with basal insulin 4 times. I have to prick myself and feeling like the odd one out. They feel very much within the group when they come across a patient group counseling session. Obviously, all of this enhances the patient's satisfaction. The patient goes home very satisfied, learning new things, knowing new things, and spending so much time with the provider, which normally they don't get. An article in India was published which said that every doctor gives roughly around 37 seconds to a patient, which is the time that they can afford because of the number of patients they have to see. But if we combine these 20-30 patients together, there is a lot more time that the patient can spend with the provider team, and hence be satisfied, which in turn will reflect on the results, on the HbA1c results and the glucose results that in turn come. A lot of questions can be answered, and in short, they feel very empowered. I'm sure they go home with learning a lot more than they already know. The diabetes educator, on the other hand, also has a lot of advantages. You can organize the same kind of people. So again, doing good homework, knowing the kind of patients that you have, coupling them together, those who have the same roughly HbA1c, those who have very high HbA1c can be coupled into one group. Those who are having counting, psychological issues can be coupled into one group, and they can all be put into a single appointment. So they can organize it that way. The jargon terms that we normally use can, we can come over this if we jointly do this kind of a discussion. Also, an educator normally, an educator normally, an educator, the teaching time can also improve. It results in a lot of self-empowerment and enhancing the understanding of the diabetes educator. The role of the diabetes educator can also be enhanced in totality. So a diabetes educator spends a lot of time with the patient, normally talking about the same things of, diet, exercise, psychological counseling. But if you're in a group and you address the issues with live examples, it helps a patient a lot more. Also, this session can be used for a lot of demonstrations, reading food labels, counting carbohydrates, self-monitoring mechanisms. All this can really help, and a lot of demonstrations can become, they can come hands-on and improve, help each other. Supposing one person doesn't know how to use the pump, the peer group helps that person because they are also using the pump in the similar format. And let's not forget that all these meetings can be a lot of fun. I remember our meeting with a group of type 1 babies, and all of you all would be remembering the song Macarena, right? So we prepared a dance on Macarena song, and you'll be happy to know that our 4-year-olds, while doing the basic step of the Macarena song, today they remember all the positions, all the shots where they're supposed to take the insulin shots. A 4-year-old from Diabetes Awareness in You doesn't have to be told where exactly the insulin shots are supposed to be told. So we make it very interactive, and a lot of dance movements, a lot of things put together. So it can be a lot of fun. Learning can also be a lot of fun. The provider also has a lot of advantages, less isolation. So in a one-to-one interaction, maybe the patient is so intimidated by the presence of the provider that they cannot speak much, which in a group discussion, we come over that fact. The satisfaction level is increased. Patient retention, very, very important for the provider. The patients normally, they do not want to come back to the provider because it's a very dull moment for them. And this is important because we need regular follow-up from the patient. We, as providers, we try to check the patient in phases. So all complications are not checked at one point of time. They're checked from time to time. Of course, very, very important from the provider's point of view, the admissions are reduced. And this is very important because we know that the economic burden of diabetes on the patient. So once the admissions are reduced, means complications are getting reduced, which is obviously a less of an economic burden to the provider as well as the patient. It's a win-win for both. And the overall quality of care also increases. This is a brief slide which tells us how these shared medical appointments actually happen. Who does it? So we get together a patients of around 4 to 20 depending on our strength. Then the participating providers, who will they be? Whether they'll be doctors, whether they'll be practitioners, diabetes educators, so depending on the patient group that we are addressing. A stepwise format can be adopted by different clinics. So in the first step, they go to the provider and they get physically examined. All the different parameters are looked into. Then they go to the educator in the second phase where counseling activities take place. PowerPoint presentations may be used. Other tools may be used to make it more interesting. Then is the counseling session, and lastly is how to take care of themselves, the empowering part, where once they leave the clinic, they should know how to go about it for the next, till they make the next appointment. When do we do these shared appointments is important, how often, how much of attention the patient needs, that patient group needs. And finally, depending on our clinic status, the size of the room and the location, how often can we have such shared appointments. This shared appointments is not a very new concept. It has been adopted by different people and tried. And in this study, we see 250 patients were actually analyzed. One was a group, they were divided into two groups, a group that got the usual care and the group that was put in shared medical appointments. And it was seen, the graph on your left shows that the HbA1c results drastically improved in the group that actually used this kind of shared appointment technique. Another group also used it amongst tribals, and they went beyond the glycemic control. They also looked at the blood pressure and the BMI, and they found statistically significant levels, because in a patient group that was addressed, the shared appointment technique, in which cultural beliefs, language, norms, behavioral pattern, everything, the ethnic and the racial disparities between people were taken into consideration. So coming back to today's topic on diabetes education and the barriers to it, we see that it starts from the physicians, the doctor himself, who are restricted and will not, share their space with the diabetes educators. There is some kind of the referral to a diabetes educator is quite limited. And I would like to use this forum where so many doctors are a part of it. Every endocrinologist, every diabetologist should, support diabetes educators, because it is a win-win, as we saw, for the patient, the educator, as well as the doctor. Another barrier could be the geographical location. So basically, education should not be limited to the doctor. It should move from the doctor to the educator and to the patients, to each individual home. So here I would just like to tell you a very famous Hindi Bollywood dialogue. We follow it a lot in the Indian culture, and it said that, God said that God could not be anywhere, and hence he made mothers to take care of the children. In a similar fashion, I think diabetologists, endocrinologists are a very, very small number. They cannot be everywhere. And hence, they should believe and they should deliver to these educators, who in turn can take care of all the patients. There can be language barriers, again, which can be, we can come over this barrier with the help of educators who can be of the local, district. Diabetes knowledge. Now, this is another angle to it. So from one end is that the doctor does not, refer to a diabetes educator. From the other end, we have that the doctors may not, trust in the knowledge of the diabetes educators. And there is where, Sir is here, Azad Sir is here, and all the big organizations can come together and make certified courses for diabetes educators, which are also of a reasonable cost, so that all our health science people can actually graduate from their different degrees and become educators, if at all they are dealing with persons with diabetes. And this can give some kind of confidence to the entire endocrinology society to then adopt this mechanism of having an educator with at every clinic where a doctor is sitting. It's like a mandatory thing that should come out of these organizations. In summary, I would like to say that diabetes education it's a key component of diabetes management, and this can be achieved by removing barriers in terms of spreading education through diabetes educators, and also reaching every home of a diabetes patient, where we encourage a mother of every type 1 to be a diabetes educator, and similarly children, siblings, their spouses, to also come forward and be diabetes educators. So the concept to be adopted by all the endocrinologists as well as diabetologists. And I'd like to end this session with a lived example. So we had a shared medical appointment with a group of people, and as always, as educators, we spoke about the diet. We also spoke about the physical activity and the importance of it in diabetes management. Another aspect that we wished to cover during that shared medical appointment is about the feet, and all these facts are already known. The tragic rule of 15, where ulcer leads to amputation, and a tragic rule of 50, where an amputation finally leads to death. And we educated them, and we drew an analogy where we asked them, the way they comb their feet every single day, comb their hair every single day, they should also look at their feet in a similar way. So we came up with this comb your feet too. And I'm happy to share with you that the patients adopted this, and there was a 25-year-old, she's a type 1, she looked at her feet every day, and I must share with you that she went to her diabetologist as soon as she found a very, very small ulcer, which could have, got undetected and got, led to this tragic rule of 15 and the other things. But she's fine today. She was able to reverse the condition. So in short, in summary, I would like to say that a lot comes out through these shared medical appointments. So it's an earnest request to all the doctors and endocrinologists that give us some space, let's understand the importance of diabetes educators through diabetes education. Thank you.
Thank you, Kiran. And thank you, everybody, for giving us this opportunity to speak. That we believe in joint work, and we cannot do anything without the help of educators. Thank you.